Welcome to Chapter 12 of Medical Law and Ethics, Death and Dying. Over the course of this chapter, we will cover the following learning outcomes. We will summarize attitudes towards death and criteria for determining death, describe the legal documents used in end-of-life decisions, identify healthcare services for terminally ill patients, describe the right to die movement, identify the major features of organ donation in the United States, and list the various stages of grief. Here's a list of key terms that we will cover in this chapter. In the past, death was not as feared as it is in the current day and age. Usually, people died at the end stages of their life, surrounded by family members who bade them goodbye and mourned their passing. It was an intimate experience shared by close family and friends. A lot of funeral rituals and rites were created throughout these stages. Black was worn by undertakers, mourners, and pallbearers to show grief. In ancient times, it was used to protect against spirits that might be lurking. The custom for mourners to go barefoot and wear sackcloth and ashes was to discourage the dead from becoming envious if they showed up in new clothing. Pagan tribes began covering the faces of the deceased because they believed the spirit escaped through the mouth. They often would hold the mouth and nose closed on a sick person, trying to retain the spirit and delay death. Traffic is halted for funeral processions because any delay in transporting a soul might turn it into a restless ghost, reluctant to pass over into the next world. Wakes that are held today come from the ancient custom of keeping watch over the deceased. Pagan beliefs concerning funeral wreaths held that a circle formed by the wreath would keep the dead person's spirit within bounds. A rifle volley fired over the deceased is similar to the tribal practice of throwing spears into the air to ward off spirits hovering nearby. And holy water was sprinkled on the body to protect it from demons. In current times, individuals are more likely to die in the hospital, or at least in the Western world, than anywhere else. Admitted into the hospital, they are surrounded by machines and isolated away from family members. Modern technology has hidden death from view and made it somewhat of a fearful thing. People are less familiar with their own mortality than they used to be, and fears associated with death and dying are universal. So healthcare practitioners need to become more aware of these and compassionately respond to family members and dying patients. Information based on a survey of adults done in 2013 show that end-of-life treatment, 66% of us would believe there are circumstances in which a patient should just be allowed to die. And 31% of us support doing everything possible to save a patient's life up until the last moment. These views sometimes change with age and when people become more aware of their own mortality. Personal preferences for treatment of an incurable disease and being in great pain. So 57% of us would ask a physician to stop treatment so they could just pass, so you could be relieved of that pain. And 35% would ask the physician to do everything possible, even if that meant living in pain and just hanging on for longer. Treatment when the patient is totally dependent on others. So 52% of us would prefer to stop treatment and relieve that burden for their family members, whereas 37% of us would prefer for the physician to do everything possible and hang on as long as possible. This could be when you are totally dependent on them, could be that you are totally immobile, someone has to feed you, clean you, bathe you, you are totally unable to do anything for yourself anymore. And lastly, treatment when the patient finds it hard to function. So you can do stuff for yourself, but it's very difficult. You are a significant burden on family members. And 46% of us would choose to stop treatment, and 46% would want the physician to still do everything they could. So for most of these, it seems the odds are pretty much the same. You know, it's that 60-40 split. The very last one, when it's just hard to function, it seems evenly split between how people would want to respond. Again, I think these numbers change based on the age group you're surveying and their own view on their own mortality. With the use of advanced medical technology, it becomes more and more difficult to determine the actual time of death. Because machines can perform many functions for the body, it becomes very difficult to determine if the body is still working on its own or if the machines are just keeping it alive. This led to the Uniform Determination of Death Act. It was proposed by the President's Commission for the Study of Ethical Problems in Medicine and Biomedical Research in 1981. This act was a proposal that established uniform guidelines for determining when death has occurred. And while each state has its own criteria, most of them have adopted the definition of brain death as the definition of death. And this occurs when circulatory and respiratory functions have irreversibly ceased. So without intervention, respiratory and circulatory systems no longer function. And then the entire brain, including the brainstem, has irreversibly ceased to function. So if the brain is not able to revive itself, there is no longer any stimulus inside of it, then most states would consider that, a cessation of life or the definition of death. This is different than a brain injury, which can induce a coma or a persistent vegetative state. So a coma is a deep stupor from which the patient cannot be roused by external stimuli. Your bodily functions continue to work, but you can't respond. People can't get your attention. Things that would normally cause a response from your body does not. Even pain in these instances will not bring you back to a responsive state. Patients can and do recover from comas. Sometimes they can be long-standing comas. The longer they're in it, the likelihood of coming out of it reduces. A persistent vegetative state is a severe mental impairment characterized by irreversible cessation of the higher functions of the brain. This usually happens when there's damage to the cerebral cortex. In PVS, or persistent vegetative state, only involuntary bodily functions are present. So your breathing, your digestive system still works. Sometimes you can swallow. Very basic skills, but you don't have any reasonable expectation of regaining significant mental function. Before pronouncing an unresponsive or unconscious patient dead, physicians perform a series of tests to determine whether death has occurred. And death is indicated when the following signs are present. So they cannot breathe without assistance. There's no coughing or gagging reflex. There's no pupil response to light. No blinking reflex when the cornea is touched. So take your finger and touch your eye and your body will blink. No grimace reflex when the head is rotated or the ears are flushed with ice water. And no response to pain. In today's society, the declaration of death occurs only when the last signs of brain and respiratory activity are gone. So modern equipment has allowed us to monitor brain waves and respiratory activity, heartbeat. So technically, death results from the lack of oxygen, because once your respiratory circulatory system shut down and the cells no longer are getting oxygen, they begin to deteriorate, and that is the true sign of death. After a patient has been declared dead, family members are sometimes asked to consent to an autopsy. An autopsy is a post-mortem, after death, examination which determines causes of death or obtains physiological evidence when necessary. Autopsies are performed in hospitals and can confirm or correct clinical diagnosis. These can be used to further research, make sure that they had the right diagnosis to begin with, and make sure that their testing is on the right paths. Autopsies are also performed in cases in which the death is suspicious or due to homicide. The number of autopsies performed each year is steadily declining, and this is for multiple reasons. One, insurance companies no longer want to pay for them. Secondly, the hospital and clinical staff feel their accuracy in their diagnosis is much higher, so there is not as much reason to do an autopsy. And lastly, family members do not always want to have an autopsy performed because it delays the funeral procession or proceedings and can interfere with viewing the body during funeral rites. Others also feel that their loved one has suffered enough, so they don't want to put them through something after death. In today's healthcare environment, individuals are well advised to be prepared for the time when they themselves or their legal representatives will have to make decisions about their healthcare and treatment and the use of life-sustaining measures. To address this concern, the Patient Self-Determination Act was passed in 1990 and took effect in December of 91. The Act requires providers to ask patients if they have an advance directive. So an advance directive is a written statement of a person's wishes regarding medical treatment, often including a living will, power of attorney, or both. These documents help ensure that patients' health care wishes are carried out if they become uncommunicative. So these advance directives include a living will, a durable power of attorney, a health care proxy, and a DNR, or do not resuscitate. Healthcare providers need to document in a patient's medical record whether or not they have executed an advance directive. Providers cannot discriminate against an individual based on whether or not they have an advance directive. So they can't choose to not treat a patient because they have an advance directive guiding some of the choices. Providers must also comply with the state laws respecting advance directives and have a policy for educating staff and the community about how to respond to advance directives. So we'll go over the types of advance directives. So a living will is an advance directive that specifies an individual's end-of-life wishes. It could detail circumstances under which treatment should be discontinued, things like coma, brain death, or terminal condition. It also details which treatments or medications to suspend. So maybe they just don't want to have invasive surgery, or they don't want a feeding tube put in, or artificial hydration. It could even be things like keeping them on dialysis and drugs for pain, but they do not want heroic measures. It can also have preferences regarding organ donations or autopsy. A living will designates someone to carry out these wishes if the patient's no longer capable of making decisions. So a living will is a great way of determining ahead of time how you would like your health care to go. A durable power of attorney is an advance directive that confers upon a designee the authority to make a variety of legal decisions on behalf of the grantor, usually including healthcare decisions. It generally takes effect when the grantor loses the capacity to make decisions, either by being unconscious or through mental incompetence. The document may place limits on the rights and responsibilities of the designee, and it may give specific instructions regarding their medical preferences. The healthcare power of attorney is very similar to a durable power of attorney, except that it's issued for the purposes of healthcare decisions only. They do recommend that you designate more than one person, though, in case your primary representative is unable to serve when called. Do not resuscitate order, or a DNR, is an order written by a physician at the request of patients or their authorized representatives that cardiopulmonary resuscitation, or CPR, is not to be used to sustain life. So if breathing stops or your heart stops beating, they are not allowed to try to revive you from that situation. It is only used in emergencies, and it does not include instructions for any other treatments. The physician will typically only write the order after talking with the patient or the patient's family and their healthcare representative. The information is placed on their chart at the healthcare facility, and most places also have a bracelet or a placard for the room when they are a DNR patient. Palliative care and curative care. So palliative care is the treatment of a terminally ill patient's symptoms to make dying more comfortable. It is aimed towards comfort care without any treatment towards curing them. It's usually pain management, symptom management. The opposite side of this is curative care, which is treatment directed towards curing a patient's disease. Palliative care or comfort care is not the same as hospice, though. Hospice is a facility or program that's often carried out in patients' homes in which teams of healthcare practitioners and volunteers provide a continuing environment that focuses on the physical, emotional, and psychological needs of the dying patient. So these services are often carried out in the patient's home. They could be in a nursing home or at a hospital, and sometimes they're at special facilities for only hospice patients. To be eligible for hospice, your physician or primary care needs to certify that you're not expected to live beyond 6 months. Hospice is usually reimbursed by Medicare or Medicaid and many private insurance companies and managed care programs. This is one of the most underused programs there is, and the general time of use is less than a week when it's eligible inside of 6 months. Hospice is carried out by multidisciplinary teams of caregivers that include physicians, nurses and home health aides, social workers, physical therapists, and others. They also help the family become prepared for the death of their loved one. They even, in some areas, have bereavement services to help with preparing a will or planning the funeral. Modern medicine has worked hard towards treatment and delaying the moment of death, but in many cases it has dealt less conscientiously with the compassion and comfort care for terminally ill patients. It also has not formally trained physicians and other healthcare practitioners to not struggle with having conversations about end of life. Medical schools have addressed this by requiring end-of-life care training within the curriculum. It is estimated that medical students now get 14 hours of training on end-of-life discussions. Nursing students have to get 17 palliative care competencies before graduation. These are in comfort care and these discussions. Medicare has also started reimbursing physicians for having discussions about advance directives and end of life with patients. These used to be something doctors were expected to do, but there was no way to bill for them. Now they are allowed to bill for these services. So some of the problems with end-of-life decisions or discussions are that physicians report they just feel unsure of what to say. Less than a third of them report any formal training on talking with patients or their families about end-of-life care. And most of them support being reimbursed for these conversations because it makes it easier to spend the time with the patient to have these conversations. And physicians who have pursued training in end-of-life discussions find these conversations rewarding and leads to better care for their patients and a more compassionate care. They also feel more confident about what to say in these conversations. Physicians can also be certified in palliative care now. There's a medical board subspecialty in palliative care. It begins with being board certified in another practice, such as surgery, family medicine, internal medicine, pediatrics, and then completing a one-year fellowship and passing an exam, the physician can be certified in hospice and palliative care. Social worker programs also offer certification in palliative care, and advanced registered nurse practitioners, or ARNP, can earn certificates in palliative care. All of these areas require continuing education units and experience in this area of palliative care to keep up certification. But it leads to better care for patients by having somebody familiar with the processes and working towards comfort care programs. Americans have become concerned that advancing medical technology has allowed quantity of life to become more important than quality of life. That ability to keep somebody alive is trumping their quality of life and any likelihood of finding a cure for their disease. It also deprives these individuals of the right to die as they wish to die. This led to the first living will, and then was first a matter for the courts to deliberate in 1976 with the death of Karen Ann Quinlan. Karen Ann Quinlan was in a persistent vegetative state for several months when her parents obtained permission to remove the respirator from their daughter. The physicians believed the respirator was sustaining her life. The parents asked for the respirator to be removed, and the physicians refused, so the Quinlans sued for their daughter's right to die. The initial court held for the physicians, but on appeal, judges allowed for her respirator to be disconnected. She continued to live on a feeding tube, but died in 1985 at the age of 31. So she lived unresponsive for almost 9 years, but that this set a precedent on the fact that she had the right to die. The doctors couldn't trump her own rights. The case resulted in the development of formal ethics committees in hospitals and long-term care facilities and hospices. It also called attention to the need for advanced health directives. This also led to the Uniform Rights of the Terminally Ill Act, which serves as a guideline for state legislatures in constructing laws addressing advanced directives. Well, there are a variety of state laws passed over the last 60 years dealing with the right to die movement. Currently, only 8 states and Washington, D.C. have death with dignity laws. These would be Oregon, Washington, Montana, Vermont, California, Colorado, Hawaii, New Jersey, and then Washington, D.C. Euthanasia and physician-assisted suicide. So euthanasia is the mercy killing of the hopelessly ill. There are 4 different types of euthanasia. Active euthanasia is a conscious medical act that results in the death of a dying patient. Passive euthanasia is the act of allowing a patient to die naturally without medical interference. Voluntary euthanasia requires the patient's consent or that of his designated representative to use medical means to end the patient's life. And involuntary euthanasia is the act of ending a patient's life by medical means without the consent of the patient or the patient's representatives. So according to current polls, there's growing support for physician-assisted euthanasia. This is also referred to as physician-assisted suicide or physician-assisted death. This is always a difficult issue. Some people say that it is against the Hippocratic Oath for a doctor to assist with someone dying when they are only supposed to never do harm. There are others that say the potential for abuse is great in a situation where a physician gets to determine whether your quality of life or your quantity of life are more important. There are others that worry that relatives of wealthy patients may petition to have them euthanized to be allowed to inherit earlier. Physicians at this point cannot legally perform lethal injections or mercy killings or active euthanasia. It's going to continue to be an area of high debate, but it's one of those quality of life, quantity of life dilemmas. If you're suffering from an incurable, debilitating disease, do you have the right to end the suffering? The debate on euthanasia will continue for years to come, but until all the legal issues are settled, healthcare practitioners are reminded that legally and ethically, they're bound to consider both the existing law and the welfare of their patients and the location of their services before proceeding. The National Organ Transplant Act, passed in 1984, this is a statute that provides grants to qualified organ procurement organizations, or OPOs, and establish the Organ Procurement and Transplantation Network, or the OPTN. The Organ Procurement and Transplantation Network goals are to increase the effectiveness and efficiency of organ sharing and equity in the national system of organ allocation, and increase the supply of donated organs available for transplantation. They also want to improve waitlisted patient, living donor, and transplant recipient outcomes, promote living donor and transplant recipient safety, and promote the efficient management of the OPTN, or Organ Procurement and Transplantation Network. Every 10 minutes in the United States, another person needing an organ is added to the list. and on average, 22 people die each day waiting for a transplant, and one donor can possibly save up to 8 lives. This is just to emphasize the shortage of organs available for transplantation. Patients should always make it clear to hospital personnel that they are wishing to donate their organs for transplant or medical research in the event of their death. This can be accomplished in several ways. Some states allow it to be listed on their driver's license. Others can carry an organ donor card in their wallet, specifying their desire to donate organs. They should also let their family members know their wishes in regards to organ donation in the event of their death. That way it's not a surprise if something was to happen. The Uniform Anatomical Gift Act was a recommendation of the National Conference of Commissioners on Uniform State Laws, in which all states accepted allowing individuals to donate their bodies or body parts after death for use in transplant surgery, tissue banks, or for medical research or education. The organs and tissues used for transplantation include the heart, kidney, pancreas, lung, stomach, small and large intestines, along with bone, corneas, skin, heart valves, veins, cartilage, and other connective tissues. This means that one donation can affect countless other lives. Regardless of our personal belief system, everyone will at some point experience the loss of an acquaintance, friend, or loved one. During this time, we need to grieve. A lot of people are unsure of how to deal with grief in their own life or to help somebody else who is grieving. So grief is the human reaction to loss. And there are two different trains of thought of the stages of grief. The first train of thought is by Elizabeth Kubler-Ross, a medical doctor who was the authority in the field of death and dying for many years. She listed the stages of grief in no specific order as denial, or trying to avoid the inevitable; anger, which is frustration and an outpouring of anger, rage, and resentment. Stage 3 would be bargaining and guilt, seeking in vain for a way out of the situation. Stage 4 as depression and sadness, the final realization of what really happened or the inevitable. And stage 5 is acceptance, finally finding a way forward. During the grieving process, stages may be skipped or one stage may be returned to repeatedly. A combination of all the emotions described may be felt at the same time. Counseling sometimes helps those who grieve, while others come to terms with grief on their own. Roberta Teams describes her perception of the distinctive behaviors of grief, first as numbness, characterized by mechanical or rote functioning and social isolation. Secondly is disorganization, where feelings of loss are so painful and disorienting, one can't make plans or decide on what to do next. And lastly, by reorganization, a return to one's previous, more normal and functional way of life. While no one list of the stages of grief is useful for everyone, most touch on the types of behavior mentioned previously and are relatable to people who have experienced or observed times of loss. Thank you for joining me for Chapter 12 of Medical Law and Ethics, Death and Dying.